On behalf of my colleagues, I would like to thank the conference organizers for accepting my abstract as an oral presentation. Unfortunately, I cannot make this meeting in person and will participate virtually. Current treatment of HBV consists of nucleoside and nucleotide analogs and pegylated interferon. To date, HBV cure remains an elusive outcome. Depicted here is the HBV life cycle and potential interventions under investigation with the hope that a cure, be it functional or partial, can be achieved. I will not go over this in detail as is nicely summarized in the recent article published in Journal of Hepatology, from which I lifted the figure, and that this will be a subject of Jennifer Kaiser's talk later today, which I'm sure will be an excellent presentation. At Janssen, we've been investigating two compounds for HBV. The first is J&J 3989, which is a fixed dose combination of two N-acetylgalactosamine conjugated small interfering RNAs, J&J 3976 and J&J 3924. Both siRNAs have rapid liver uptake via the asialoglycoprotein receptor due to the N-acetylgalactosamine. In plasma, we see very short half-lives, approximately 6 hours, and after 3 days, plasma concentrations are virtually undetectable. However, from preclinical studies, we know that there's a prolonged residence on the RNA-induced silencing complex, such that the liver half-life is measured in weeks and allows us for once-monthly dosing. The mechanism by which siRNAs work is that they deplete the viral mRNAs and the pregenomic RNA, reducing basically all the HBV proteins, including surface antigens. And in vitro, we've studied both cytochromes and transporters, showing no effects on either the CYPs or the transporters. The second compound we're investigating is J&J 6379, which is a capsid assembly modulator. This induces the formation of empty viral capsids, essentially accelerates the formation of the capsid such that the pregenomic RNA can't be encapsulated. We evaluated the combination in two phase 2 studies, REEF-1 and REEF-2. In REEF-1, we had active chronic hepatitis B patients either not currently treated or virologically suppressed, receiving nucleoside analogs and placebo as standard of care in the gray. In yellow, we had 6379. In the blue, we had increasing doses of J&J 3989, 40, 100, and 200 milligrams with 6379 placebo, and they were on nukes. And then we had the triple combination regimen of J&J 3989 at the 100 milligram dose with J&J 6379, 250 milligrams and nukes, and they were treated for 48 weeks with a follow-up period off treatment. In REEF-2, we studied virologically suppressed and HBe antigen negative subjects receiving, again, standard care with nukes and the triple combination regimen, but this time dosing with 200 milligrams of J&J 3989. And in both studies, participants could have the option to participate in a pharmacokinetic sub-study. I'll show you here the REEF-1 results. This is change in surface antigen over time for the nukes. You can see that there was no change. Similarly with J&J 6379, this is very consistent with previous results. With increasing doses of J&J 3989, here we're showing the 40 milligrams, 100 milligrams, and 200 milligrams. We see a dose-dependent decrease in the surface antigen on treatment, and then notice that when they're off treatment, there's a slow rebound of the surface antigen, although it doesn't go back to baseline. Now, interestingly, when we combine the three, so this is the triple combination arm with 100 milligrams of 3989, so the best comparison is this arm here. You can see that there was less surface antigen decline with the triple combination, about 0.3 log difference. We will be presenting the REEF-2 as a late breaker at AASLD. So I can't show the results here, but let's just say that it's consistent in that we do see a decrease in the surface antigen when adding the 6379 if we compared it to the 200 milligrams results here without 3989. Fortunately, as I mentioned, we had an optional PK sub-study in which we could assess the pharmacokinetics. So either at week 4, 8, or 12, participants had their blood drawn over 24 hours. Plasma samples for J&J 3976 and 3924 were analyzed using fluorescence hybridization. If they were on 6379, they were analyzed with liquid chromatography, tandem mass spec. And we did standard non-compartmental analysis. And I also include data from another study of healthy participants just as a comparison for their PK. So here I summarized the pharmacokinetic parameters. I'll walk you through this table. On the top are the J&J 3976 PK parameters. On the bottom are the J&J 3924 parameters. And then as we increase in the, as we go across to the right, the increasing doses of 40, 100, and 200 milligrams. From the REEF-1 study, in the REEF-2 study, the 200 milligram dose, and then this is the healthy participant comparison. So just looking at Cmax and AUC for both compounds, you could see that between 40 and 100 milligrams, there was a little greater than dose proportional increase, but then between 100 and 200 milligrams, you could see that the increase is approximately proportional, and that there was no apparent effect of adding J&J 6379 on the pharmacokinetics. And then you can see here that these results in patients with chronic hepatitis B, but non-cirrhotic, very similar to healthy participants. These are the plasma concentrations illustrated graphically. Just point out again that here on the left are the 3976 concentrations, 3924 on the right. The increasing concentrations going from 40 to 100 and 200 milligrams in the solid lines. The healthy participants are shown here in orange. The patients are in blue. The dotted lines represent the patients who were also on 6379. So again, graphically, you could see that there was really no effect of J&J 6379 on the plasma pharmacokinetics. We also evaluated the pharmacokinetics of 6379. Again, you can see here in patients either with or without the 3989, the concentrations, the Cmax and the AUCs are very similar, and the plasma concentrations were no different between those patients. Of note, you can see that the plasma concentration is pretty much a flat line for 6379. This is because it has a very long half-life, a little over 100 hours. So that leaves us with the question of why was there this decrease in the surface antigen, and perhaps it's a pharmacodynamic interaction. And internally, we debated, is this because it's compound specific or is it a class interaction? And ultimately, we think that it may be a class interaction. However, there are other companies evaluating the siRNA and CAM in combination, so it'd be interesting to see if they can corroborate our findings. So as I mentioned, 6379 is a CAM. It induces the formation of empty viral capsids. That is, it doesn't allow the pregenomic RNA to be encapsulated. So what happens to that pregenomic RNA is it resides within the hepatocytes. And again, it's a substrate for the RNA-induced silencing complex loaded with the siRNA. So what we think is happening is that there's less ability for the siRNA to work on the viral mRNAs that lead to production of the various proteins. And so we think it's interfering with potentially the, therefore interfering with the surface antigen decline. And that's why we see a slight decrease in the surface antigen when we combine with J&J 6379. So in conclusion, in patients with chronic hepatitis B from our phase 2 studies, REEF-1 and REEF-2, there was no apparent interaction between the two compounds based on the plasma pharmacokinetics. The plasma pharmacokinetics in patients appear very similar to the healthy population. keeping in mind that our patients are non-cirrhotic. And further studies are needed to elucidate this mechanism behind the lower surface antigen decline with 637. When J&J 6379, the capsid assembly modulator, is co-administered with J&J 3989, the siRNA. I'd like to end by acknowledging the REEF-1 and 2 investigators, the site personnel, and participants. The study was sponsored by Janssen, and medical writing support was provided by Tim Caldwell. Thank you very much.